pediatric doctor and integrative and holistic medicine. And I'm glad all of you are here. I don't want us to get depressed because there's not a lot of people. I think that every presentation we make is a step towards the next presentation. All of you are young. Just think of this as practice for when you're in front of 1,000 people. Okay, because I don't want us to be all upset because there's only a few people here. And you never know where this information will end up. Might end up on the internet helping somebody that really needs to hear what you guys have to say, you know? So I just believe I'm probably not supposed to bring in God, but God or the divine being always brings together the people that need to be together. So I think we should start with that idea in our mind, okay? Because I know I'm sitting here thinking there's only a few people, but you never know. I mean, maybe the few people that are here will be the people that make some huge difference. Maybe we'll make a big difference in each other's lives. That's totally off script because I always go off script, and I'm sorry about that. Is it time to start, Max? Yeah? Can you hear me? Can you hear me through here or just my regular voice? Because I don't know. You can hear me? Okay. Where are you from?
From Tunisia.
Tunisia. Hello, Sahla. And your topic sounds very interesting to me. I never even thought about the orthodontics for kids with like sleep apnea and stuff like that.
Avoid many patients.
Yeah, I think that's great.
You can see the
Yes.
to present some cases. You can see.
It's really interesting to me because I was thinking, I never thought of that. I've been a pediatrician for 40 years. I never thought to send somebody to an orthodontics to fix their sleep. How about you?
The same.
You're from Tunisia too?
The same specialty.
Oh, really cool.
Yeah.
It's nice to meet you. And you are from
Mauritius.
Mauritius? Oh, I've never met anybody from Mauritius. Maybe, Max, you shouldn't be recording this because this is totally off script. Okay. Okay. Is that better? I don't really think we need a microphone.
Okay.
Can you hear me without a microphone? Yeah, then I'm easier without a microphone. From Mauritius, and it's hello, Sahla. I'm not from Malaysia. I come from Jordan, so I'm welcoming you to a country, but you know, it's all God's land. Sorry again, I don't mean to do that. And you're from Kazakhstan, and you are from
Mauritius.
Mauritius.
We are from the same.
Beautiful. Well, it's very nice to meet you. So we have Africa and Asia, right? Africa and Asia represented here. Good. Two very big, very important continents. Okay, so I have to read this, it seems. Okay. I'm Dr. Linda Abu Jaber, and I'm the chairperson. And a very good morning to all. On behalf of the organizing committee, it's a great honor to welcome you to the 5th World Congress on Child Health, Pediatrics, Gynecology, and Obstetrics from June 18th to 19th in the AC Hotel in Kuala Lumpur. It gives me immense pleasure to welcome all of you. Do I have to read this, Max? Because I've already, okay, sorry. It gives me immense pleasure to welcome all of you. And really, we do have a mission to advance maternal, fetal, and child health care in the world, don't we? Foster innovation and improve health outcomes for women, children, and adolescents worldwide. And hopefully for men also, because I think that the role of fathers is very neglected in the world. And that's actually one of my passion projects, is educating dads how to be really involved and what's the word? Conscious fathers. This conference serves as a dynamic platform for exchanging knowledge, fostering global partnerships, and inspiring progress in pediatric, child health, and gynecological research and practice. So I think we should look forward to an engaging session this morning. And hopefully we can learn something new from each other, and maybe we can start some new partnerships across continents. So, hi, I'm Dr. Linda Abu Jaber, and I look forward to an inspiring and productive day with all of you. The UCG conference, usually this conference is held in Dubai, and maybe that's why the attendance is less because, you know, with the stuff going on in the Middle East and everything, everybody was afraid. but I decided to risk it and come to come to Malaysia because I've never been here before. And it's nice to explore new places when I still can, right? So the UCG conferences leads in organizing professional meetings, conferences, workshops, and symposia across the medical, clinical, healthcare, life sciences, and pharmaceutical sectors. It bridges academia and industry, driving excellence and innovation in every event it organizes. With global reach, 24/7 support, and a dedicated organizing team, UCG ensures that each conference is impactful, memorable, and tailored to the needs of its participants. On behalf of UCG, I extend heartfelt gratitude to the organizing committee, our esteemed speakers, because it seems the speakers and the attendees are the same today. So maybe we can have some really good dialogue. And all participants whose contributions have made this event possible. Together, we're advancing the future of pediatric and adolescent healthcare worldwide. Keynote speakers like me are going to speak for 40 minutes or less if you want me to. And the speakers got 20 minutes, but because we're small attendance, I don't want you to feel rushed. You can go ahead and present your findings because I know you worked hard at your presentations, as did I. So this morning, ladies and gents, well, I'm a lady too, and ladies and gentlemen, our first speaker is Dr. Umid Rustamuli Ali Muhammadov. Did I get it? Yeah, he's a neonatologist intensivist from Kazakhstan. He will be presenting evaluation of the effectiveness of a complex of minimally invasive technologies in stabilizing the respiratory status of preterm infants, which is a very long way of saying how to save preterm infants' lives, right? That's ultra cool. Please join me in welcoming Dr. Umid Rustamali Ali Muhammadov. I forgot my coffee. Sorry. Oh, you press there. Yeah. And you can choose but Max is here for technological support.
Good morning, dear colleague. My name is Umid Rustam Lali Muhamedov. I am neonatologist and PhD candidate from the Scientific Center.
Microphone, would you?
Oh, okay. I am neonatologist and PhD candidate from Scientific Center for Obstetrics, Gynecology and Pediatrics in Almaty. Today, I would like to present our study on the effectiveness of minimally invasive technologies in stabilization of respiratory status of extremely and very low birth weight premature infants. Prematurity remains on the leading causes of neonatal mortality worldwide. Respiratory distress syndrome is the most common complication among premature infants. Modern minimal invasive approach may significantly improve outcomes and reduce complication associated with mechanical ventilation. Despite significant advance in neonatal care, mortality rates among extremely premature infants remain high in many countries. The lawful implementation of evidence-based respiratory support strategies is critically important for improving cervical and long-term outcomes. The aim of this study was to evaluate the effectivities of compressed minimally invasive respiratory support strategies and extremely low birth weight and very low birth weight premature infants. Immediately after birth, stabilization begins with proper position, thermal protection, monitoring, and initiation of non-invasive respiratory support. Early CPAP is implied whenever possible to maintain for functional residual capacity and avoid intubation. If respiratory distress progress, minimally invasive surfactant administration is performed. The goal is to provide surfactant therapy while preserving spontaneous breathing and avoiding mechanical ventilation whenever possible. After surfactant administration, continuous monitoring and supportive therapy and provided. The infant's respiratory status, oxygen requirements, and vital signs, and closely observed in successful stabilization. This coffin benzoate, this surfactant. First pictures, surfactant. Its protocol. This study includes premotor infant with gestation age between 22 and 32 weeks and birth weight below 1,500 grams. Clinical outcomes were assessed using standardized respiratory and neonatal parameters. Strict inclusion and exclusion criteria were applied in ensure homogeneous study population and reliable assessment of treatment effectiveness. The study population include infants with different gestational age and birth weight categories. Baseline characterized with comparable between and analyzed groups. Yes. Most infants received evidence-based perinatal intervention, including delayed cord complaint and antenatal corticosteroid therapy, which contribute to improve respiratory adaptation after birth. Yes. The majority of infants were successful managed using non-invasive respiratory support methods, primarily CPAP and high-flow nasal cannula therapy. Minimally invasive surfactant administration scientifically reduced the need for invasive mechanical ventilation and allowed preservation of spontaneous breathing in the most patients. Our results demonstrated reducing in bronchopulmonary dysplasia and improved survival rates among infants treated with the minimally invasive respiratory support strategy. The implementation of minimally invasive respiratory technologies provided significant clinical benefits, reduced complication, and improved overall neonatal outcomes. In conclusion, minimally invasive respiratory support strategies are safe, effective and feasible for extremely premature infants. This approach may reduce mechanical ventilation, exposure, and improve cervical without increasing complication. Uh, uh, Thank you for attention. I show my videos in work. My English is not good. Uh, excuse you.
You did very well. And just on an interesting note, when I was training, 22-week babies were not even considered for resuscitation, young too little. I remember 26 weeks was the smallest that we ever had any. And I remember when ECMO first started, I don't know if ECMO was still a very new technology back then. I mean, just to give you a contrast and how life has changed since then. A 20-weeker we never would have done anything with. We would have, cried and been sad. But so this is fantastic, and you don't have to mechanically ventilate even a 22-weeker sometimes.
Yes.
Wow, that's fantastic.
I show 23 weeks baby, 520 grams this video. Yes. Is
How big it was. I remember I took care of a 26-weeker that was 500 grams, and she was from here to here. Just to give you a context.
short.
I'll be scared. One shot of fire and dreams hang in the air. Falls in the sky and in my wide. You know it feels unfair. There's magic everywhere. Look at me standing here on my own again. I'm straight in the sunshine. Something in your eye, that is in your head. You seem to hate you. Harsher than I need a friend. Oh, I need a friend. You make me happy. I stand here on my own. Look at me standing here on my own again. Up straight in the sunshine. I'm so alone. I just see again, sunshine fills my head, and dreams like in the air. Falls in the sky, and in my pride, you know it feels unfair. There's magic everywhere. Look at me standing here on my own, up straight so
Thank you.
So you got her up to the 90s without even giving surfactant.
Yes,
You're very brave.
yes, and no intubation, and no operate eval, only CPAP.
Yes, that was
Yes.
fantastic. I'm sorry, as an old doctor, I found that really exciting. I was sitting there waiting after you gave the surfactant, then the oxygen went down and she stopped breathing and then she started.
Yes, and
That was like watching an action movie.
we see not bronchopulmonary dysplasia.
Yeah, it's
So,
down,
yes,
right?
yes,
It's
and
fantastic.
retinopathy because no oxygen. You see, 21, 21, only 21.
Real-
No oxygen. Yes.
Sorry, it's really exciting.
Thank you.
Thank you. You need me, oh, come in, oh, you want me to give it now? So I'm gonna give you a certificate of participation. How do you want me to do this? You can call him, just call him up. Come up, Dr. O'Meara.
In front of them.
I think I should call you miracle worker. I was sitting there like,
So
Yeah, out of the light.
Yeah. Come this.
oh, this way?
This side,
Yeah.
yeah. Okay.
Here.
All right, ready, 1, 2, 3, nice, one more, yeah. Okay, got it, thank you.
Thank you.
Thank you for the work you do.
Thank you.
Sorry, I'm just, I guess I'm excited. Okay, now we're pleased to welcome Dr. Budwashar Kumar Juglav, founder and executive director of Anrav and Surya from Mauritius. What does all that stand for, NREV and for?
One dream, one spot.
Oh, yes, it sounds like French.
Yeah.
Oh, the title of the talk is Patient Navigation and Access to Specialized Care, which is transforming childhood cancer outcomes in a resource-limited setting. The experience of NREV and Sarir. Please welcome Mr. Woodwashar Kumar Dubla.
Hello. Sorry, I'm a bit long. Good morning, everyone. I'm Budishwa Kumar Jaglal, founder and executive director of NGO NREV and Suria from Mauritius. And today I am presenting on how we help Mauritius to bring on a specialized childhood cancer program in 2023. So just for the general context, the WHO launched the WHO Global Initiative for Childhood Cancer in 2019. And the main goal was to raise survivorship up to 60%. And it will be impacting 1 million children around the world. So we notice also that in high-income countries, we have more than 80% of survivorship, and in low-income country, we have 20 to 30 survivorship. So the aim in 2030 is to upgrade it to 60%. So some of the key challenges that we have, it's one of the main is late diagnosis, limited access to specialized healthcare, shortage of trained healthcare professional, limited liability of essential cancer medicine, financial burden, and insufficient support to parents and children, and also weak policies in country, especially in middle countries. Sorry. So in Mauritius is a short island in the Indian Ocean, where we have only 1.2 million population. It's a upper middle income country. And I would like to highlight that the public health is free, access to everyone. And the NGO where I came from was founded in 2016 as a pediatric NGO. We have supported more than 2,000 patients during the last decade, and we are also recognized by three international organizations, namely the SIOP, International Society of Oncology Pediatrics, the CCI, the Childhood Cancer International, and the UICC, Union for International Cancer Control. And in childhood cancer in Mauritius, we have approximately 50 cases annually based on the statistic, and the most common are the blood cancer and brain tumor, and we have also the lymphomas, white tumor, etc. And before the introducing of the scheme, the survivorship was about 18 to 20%, which was very low, according to our statistic and the population. And the main challenges that we use to get is late diagnosis, limited awareness. We don't have any specialty, any oncology pediatric on the island, and we had many financial burden on families, limited psychological support, and not even a proper policy by the ministry to take charge of children. So we find out that in the country where there is no pediatrician, no specialist, the interest in childhood cancer in pediatric research is very low, which had not come yet with a proper taking charge of children, or we have not come with a professional, high standard pediatric healthcare. So our approach and advocacy to change these things, we have shown that we have put in place in 2019 a program to raise awareness on the real facts and also to break down the project, how to better manage, manage childhood cancer. And also we have also present these cases to the Ministry of Finance because, you know, when the fundings are going in a place where there is no professional in pediatric, there is a misuse of this. So we break down to the different ministries so that we can show them that if we properly use the fundings and put a good structure, it will change the outcome of the country. And this is what we have done. And we have shown them how much of the cost. In Mauritius, I would like to highlight that we don't have any proper pediatric oncology unit or any pediatric oncologist. So we had to break down the project in all levels, from the awareness, the case management, the treatment access, patient navigator, and so that they can understand how things work. And we also highlight that, you know, for a 1.2 million population, the budget for a childhood cancer it represents 0.8% on the national budget, which is not so huge, because when the Ministry of Health also fund, they mix everything, children, adults, and everyone in it. So, and then when the funding went to the Ministry of Health, it is lost and probably not used in the correct way for the children. So services that we have put in place in the project was awareness to promote early detection, access to treatment. We have facilitated the overseas treatment access. We in Mauritius work principally with India. We have many MOU, government with government and government with private clinics. So we have put in place a system when children with symptoms and a confirmed diagnosis, we don't lose time, we put them in a plane and they go to India. So also access to treatment. We have also established a very good structure follow-up concerning the patient navigator from Mauritius to India and back to Mauritius, and also to maintain a proper follow-up during the next 5 years. And also it includes everything. So patients don't need to worry about tickets, visa, or anything. Everything is taken in charge by the government. Additionally, when we send a parent and the children abroad, so obviously we have to cater for accommodation, for living allowance. So it is also included, and also all patient is assisted by a personal social worker, trained one, from our NGO, and also a continuous support on the psychological and psychosocial aspect concerning the children and the family. The scheme also include the medical follow-up after the main treatment, even if you have to go abroad again. So we go abroad, and also sometimes we also can have relapse cases. So we take in charge all these things. And also for palliative care and parent who has lost their kids, we also cater for them. And palliative care for children was something that was not available in Mauritius before, and we had worked with specialists from the private and the public so that we can merge the strengths so that we can take care and reduce the pain of the children. And also for parents, there is assistant psychological support that is provided so that we don't let them like that, and we have a continuous support. It grew accordingly to the professional. And also we have started a survivorship program because before there was nothing, and survivorship was even very less. So there was not focused, no program for them. So we have included also a special survivorship program to try to get them back to a normal life. So after 2018, through our advocacy, in 2023, the government came with a national cancer scheme. And it was, this is just a photo of the articles where it returns about the introducement of the child cancer scheme in 2023. So the impact of the child cancer scheme, as you may see, before, when there was no scheme involved in 2001, the survivorship, the number of patients was 10, and in 2022, 11 survived. And since we introduced the scheme, it started to raise to 16, and 2024, 36 was diagnosed and was alive after 1 year of treatment. And 2025, the last number that we have, 33 was alive and diagnosed. So the scheme has improved the early detection and also quickly reference to specialists, international hospitals. And we have put more emphasis in public awareness, not only for public, but also program was set up to send doctors overseas to learn more about the childhood cancer, and greater media engagement, because this was something which was not talking. We were just talking about the Cancer Day just once a year, and now every 3 years we have bigger campaign on the island to try to detect the children as far as much as we could, and also foster access to a specialized treatment, as I said, reducing treatment abandonment, because the pay rate also is well supported. And we have improved access to, new therapies like the protein therapies. This was something that children had just got access 2 years ago with the scheme. And we have reduced one thing which is very important. We reduce the stress of patients and families. And also we have taken charge those who have lost their children. So, as I mentioned before, after we have introduced a scheme, one of the most, I would say, dark side of the thing is when they change in government, and this is which has also affected. When you see in the statistic before, I showed only 2025 August. There was a change of government just after that, which has also put the project in freeze and had changed some step in it and tried to put things in their way, and therefore we had lost children, to be honest, and it is something that we have decided to put it forward, because it is very important when we are dealing in low and middle income countries where there is great influence of politics. It is very important to try to work on sustainable policies, long-term commitment, and also the protection of children's healthcare, because it might affect it, like we have experienced it. And through advocacy, we have a right to stop the new government to don't cancel everything, and just to, try the best to keep it as it is. So conclusion, no children should die because where they are born. So it is very important to work together to ensure that every children has an equal chance to survive and thrive. Thank you very much. It was Karen.
Thank you. That was very nice. In Jordan, we have the huge cancer center, and my friend and I have a friend who's a pediatric oncologist. And we always complain that there's no follow-up, no bereavement, no psychosocial, we don't know how to they don't do anything to reintegrate them into school again, because, you know, the whole family struggled because they have a sick child and then there's always a sick child, even when they get better, and they have behavioral problems from chemotherapy and stuff like that. So I think that's fantastic. Have you ever talked to the KHCC? The King Hussein Medical Cancer Center?
No.
It might be something to think about, because you'll find some people there that are actually interested in doing what you're doing. Because like I said, I've offered to do that because I believe psychosocial is really important too. And follow-up, but nobody seems to be interested. But maybe if you show them that it can be done in a teeny tiny country with 1.5 million people, it would be great. Another question I have, which is not my business, but have you thought of, do you have just general doctors and, or do you have like pediatricians?
Actually, we do have some pediatric specialists, but they came in the public sector first. When they noticed that there is no real commitment investment in the public sector 3 years.
Yeah.
I remember 2 of them. They came back from France and Europe. They had stayed in the public sector for more than 8-10 years and waiting for the government to bring some support. You know, they decided to leave at the end of the day. So therefore, they are in the public and the private. And when I got the opportunity to put in place a scheme to work together with the government, so I tried to bring them back and to work under the same roof. So we have a pediatric surgeon on the island and 3 NICU specialists, and that's all.
And that's it. Have you thought of maybe taking some money and investing in educating a kid?
In the scheme,
Yeah.
it was also predicted in the awareness and the future of the program to send our SC student to get scholarship to go and study medicine and all, and also to bring some doctors to work in Mauritius, and also to empower those who are oncologists that is working in the public sector to get them scholarship in South Africa, in India, learn about the pediatric oncology.
And then maybe you can invest.
There is 2 years that the new government has established, and it is very important to highlight this thing that because children is losing life because of this change. It's true. I used to hear it before, but now I can see it. And everything is on the freeze mode, and we don't know how when they will call us back, and everything is. I even not involved in the scheme anymore. So everything stopped at the surface.
Well, I hope everything starts. Come on up and put your thing. Unfortunately, governments will do stuff like that.
Guys, ready? 1, 2, 3. One more, yeah. 1, 2, 3. Okay, got it.
Thank you.
Shake your hand. Don't give up.
Of course.
Children are very important. And you have 3 NICU specialists and no pediatricians?
We do have a lot of pediatricians.
But they're in the private?
They are also in the public, but they don't have the experience really that to be working with childhood cancer.
Have you thought of doing like lunches online where they don't have to leave their clinics and you give them lunch and you do training? Because doctors like lunch.
We need to organize it.
Well, it's true, right?
Yeah.
Doctors like lunch, and then we don't have to leave the clinic, and then everywhere, because we have that problem in Jordan too. I mean, kids go from doctor to doctor until somebody finally thinks that the kid might have leukemia with the 40,000 white count. So it's an education thing. So again, it might be something to think about.
In the government side, we need to wait for them so that we can continue to implement it.
Oh, you can't, because I thought you were an NGO. You're government affiliated.
We were involved in the policy making.
Well, you don't have to make policy. Just go to the doctor, say, I'll give you lunch if you sit for half an hour and talk. We'll talk about childhood cancer.
Yeah.
It's something to think about. I'm sorry. I'm just,
No, sure. Bye.
Because, yes, you're welcome. Okay, thank you very much for your valuable insights. Now we are pleased to welcome you. No, that's the wrong. It's our pleasure to welcome Dr. Hamza bin Isa, an orthodontist from Tunisia. His topic is orthodontics as a key determinant of psychological, aesthetic, and functional balance in children and adolescents. The role of maxillary expansion in enhancing breathing and sleep quality. Please join us in welcoming Dr. Hamza bin Isa.
Thank you so much. Hello, everyone. It's a big pleasure for me to be here in Kuala Lumpur. I'm Dr. Bin Isa Hamza. I'm orthodontic. You know that we study first dentistry and then we are specialized in orthodontic treatment. Orthodontic method is about the treatment of the lower third part of the face. We not just focus on alignment of teeth. We can treat some skeletal discrepancy, some problem of breathing, especially on child and adolescent. I start my presentation to present first the effect of the maxillary expanding on breathing. What the relationship between expanding the maxilla and the breathing? You know that the bone constituted the maxilla is the same that is constituted in the cave or the nose cavities. When we expand the mid-palatal suture here, exactly here, our action is at the middle palatal suture on the maxilla. When we expand, we can open the nose cavity and we can also get more better breathing. We enhance the volume of air by breathing. Here, you know that I can show you this video that explain well how does it work. No, don't worry, it's not painful at all. Just one activation per day. It's not painful, and don't worry about this. For the skeletal effect, when we open the mid-palatal suture, we can see that the nose cavity is more better, the zygomatical area is become more better, and the arch wire it's switching from narrow to broad arch. The smile is becoming more better too. Some patients, some adult patients don't need to inject hyaluronic acid on the zygomatical area, just they need MARPI to expand the mid part of the face. We start with this patient. This patient, he has 7.5 years old. We avoid patient from surgery. You know, this patient, the big problem in this case, snoring all the night. He can't sleep well. He wake up many times all the day. His parents are very worried what to do for their child. We note here that the upper arch is very narrow, very, very narrow. And here we have posterior crossbite. Normally, at the normal situation, we have the upper arch cover the lower arch. That's the normal situation. But here is not. It's the opposite. We have the lower arch cover the upper arch. It's abnormal. We can see the quality, the lips of the patient. We can see the under eye circle and the facies adenoidea in French we speak. So we treated with this patient with expander, simple expander. Expander for children don't need screws. It's soft because the mid-palatal suture it's open. This opening is not closed yet. So we do one activation per day. The parents do the activation themselves in home. They don't need to come to my office to do the activation each day. I just give the patient one appointment after 2 weeks, sometimes one appointment after 4 weeks. It depends on the amount to expand. And here we saw that we expand the maxilla, we get enough amount of expansion, the breathing is becoming well. Don't worry about the space. They collapse himself without anything because we have in the gummy, we have the transversal fiber that close the space spontaneously. Don't worry about the space. Here, X-ray comparison before expansion and just after the expansion. We can see the amount of the expansion of the nose cavity. It's become more better. And I have just little video that the patient and his mother spoke about their experiences. I asked the patient how to spoke about her experience with the expander.
وش لاحظت انت في وجهك البارتيه ايش لاحظت؟
Sorry, it's in Arabic. May I translate it in English?
في الريسبيراسيون نحس
Her mother said that before he has mouth breathing, but now he's switching to nose breathing. We show other things that no snoring on the night. He's sleeping well. The quality of sleeping is become more better.
بالنسبه للاكسبونسيون ولا الاكسبونسيون تاع البوميت دوزوماتيك هذا اللي هو اللي
She spoke about the expansion of the mid part of the space.
باش يجي الباسون يتنفس بالكدا. إذا بالنسبه لك انت لقيت شويه قلق بالنسبه مش قلق يعني بالنسبه لك انت في التنفس شنو اللي لاحظت الفرق؟
You can look at the orifice of the nasal that become more.
برافو فرحان ولات اهم حاجه ذاك اللي حاجه نعيدوك عليه ذاك صحي.
Another cases, the same problem. This patient snoring all the night, wake up many times all the night. He feel tired at school. He didn't concentrate. But on these cases, we have a lot of crowding, a lot of tooth crowding. So we recommend to do this patient two expander. The first expander to resolve the breathing problem, and the second one to treat the crowding problem. Another problem for this patient, he didn't expose incisor when smiling. Her friend smoke of him and make fun of him. So the procedure, it's easy. We do expander, 1 activation per day. All the treatment is just 2 or 3 months, not long period of treatment. And you can see in few months the difference on the smile. When we expose, when we make more better the white of the upper arch, the upper incisor comes down. And the smiling, we enhance the smiling, we enhance the white of the upper arch, and at the same time, we correct the breathing of our patient. Here, X-ray comparison before and after the first expander, and then we do the second expander. When we analyze the face of the patient before and just after the patient first expansion, we saw the difference. We saw the difference of the under eye circle, the lips, the nose, the shift midline, it's corrected because of the recentration of the mandibular. The position of the mandibular usually is related to the maxilla, to the wide of the maxilla. When we expand the maxilla, we get spontaneously recentration of the mandible. Not surgical. We don't need surgical to recentrate the mandible. And her mother spoke about her experience with the expander. The same that the first patient, she said that the under eyes circle disappear, snoring, not snoring at all. The quality of sleeping is become more better, and he gets more energy at school, more concentrating in her at school.
نجم تقعد مدة كبيرة عمل في السكن ولا لا؟
She spoke he spoke about the switching from mouth breathing to nasal breathing.
تحت اللسان تحت الجلد تحت العقبات الحمد لله
نحط الوجه حتى وجه الضوء مع الشغل.
فأنا طبعا اللي فوق
He gets more pomatical area.
اللي كان بيختلف فوق من البشر وقت بالله يبقى عليك ولا مش مع ولا تشبع
She said that when he's sleeping, he's full sleeping without waking up. Before he can't. Other patient. In this situation, the problem here more than breathing, the problem is usually aesthetic, especially for girls at school. Her friends make fun about her, they mock about her, they said that your smile don't look well, you don't need to joking with us, many. So we recommend for this patient to do first an expander. Why expander? To create space for the upper incisor, because we have 4 upper incisors, and the white of the arch and the white of the teeth, we had discrepancy between them. So we need to expand to get more broad upper arch, to create space, to put the upper incisor more alignment, and to get more aesthetic results for our patient. At the same time, we expand the nose cavity, and so we resolve the breathing problem. X-ray comparison, we saw usually that some teeth change the direction of eruption, especially for the canine. Here, she can smile. It's in progress case, not finishing, but she can smile now. Now for adolescent. For child until 13, 14 years old, the mid-palatal suture is open. We use a simple expander, classical expander. We don't need soft hard one. But at age 15, 16, 17, 18, we need to use some screws, bone screws. In some cases, we need 2 screws, sometimes 4 screws. The role of screws is to lift the midline, to get more anchorage, to open the mid-palatal suture. Don't worry, not painful at all. Here, we can see the wide nasal cavity. We can see how expand we can. We don't need to do tonsillectomy or adenectomy. We open the posterior airway without surgery. 1 activation per day. Sometimes we recommend 1 activation or 3 days or 2 days. It depends on the case. I had patient. It's a sportive patient. Her problem especially is about smiling and about the posterior crossbite. Crossbite here, the same. We note that the lower teeth cover the upper teeth is not normal at all, and it creates a problem on the angina articulation. So we need to expand the upper arch to correct the relationship between upper and lower arch, to recentrate mandibular in the central position, and to get more better arch smile. So for this patient, we recommend to use other type of expander. It's MSE. 4 screws. We put the 4 screws on the palatal surface. For the screws are bicortical. We put the screws from the palatal surface to the base of the nose. Bicortical. We need bicortical to get more anchorage. You saw that we open up 5 millimeter on the palatal feature, and we correct the posterior cross-side. The width of the arch it becomes more better. We asked the patient about her experience. She said that he got Hollywood smile. Hollywood smile, yeah.
بس دي صار بس لاحظت هيك بعد 6 شهور صرتوا
We take 6 months. In adolescent more time than child. She breathing more better. Breathing.
واسمع في الفكر فوقاني الاسباس اللي يتحل من هنا هو نفسه الاسباس يتحل في الشم من هنا الباسون اللي بسمع قبل يتحل يعني كان فرجة بالقضية اللي يركب معه الفرجة هذيك هي تتحل فوق الشم انت عرفت الشم واللي نجم كيف تدور.
Don't worry about the space. We close it with simple appliances. The main objective is to get Hollywood smile, to get breathing well. That's the main objective. Space, it's easy for us to close space between teeth, not so difficult.
Smile.
She smiled a lot and she's happy about the smile that she get.
طلعنا الفيلم وما طلعناش.
We do treatment without premolar extraction, without extraction of teeth. The traditional way to treat to alignment teeth is to put some extraction. Now with expander we don't need extraction, exception of wisdom teeth. Other method. She showed me how to activate. She activates quickly, easily. She tried. She is very. Other thing, she is a sportive woman and she so sportive girl, and she feel more energy when doing activities, not tired at all. I asked the laboratory to make superposition for this patient before treatment and after treatment with expander. We saw that the zygomatical area and the arch of the upper arch are expanded. In green, it's before, and yellow and violet after expansion. In blue, the posterior airway. She show us that the volume of the posterior airway is become more better. We enhance the posterior airway volume.
And this is an adult?
She's an adult, yeah. She's a Syrian Turkey, our prothesis, orthodontic prothesis. She do the appliances for us, for doctors. She is a very, very, very good person, and she do a very good job. Here at the end, the smile of the patient, it's in progress case at the last phase of treatment, not more. Thank you for your attention. If you want to follow me, you see the result of our cases, you can follow me on Instagram or on LinkedIn. I publish a lot of my cases and on my experience with my patient. Thank you so much.
Thank you, Dr. Hamza, for sharing your experience. That's with that. My son had I never knew, when my son was young, he had his teeth on top of each other. They said there wasn't enough room in his maxilla. So I used an expander, never knowing what was going on. So now I'm thinking what I was doing with my son. And thankfully it's not painful.
No
It
painful.
was very sympathetic.
Not painful at all. Thank you.
Thank you. This way? Okay.
Yes, way.
Ready? 1, 2, 3.
Thank you. Thank you so much.
Thank you. Now, I think we have a coffee break now. What time is it? From 11 to 11:20 or 20-minute coffee break. And after that, I'm going to speak about using antibiotics in kids. Do you have any questions or anything? I think it was a very nice morning session, yes? See you in 20 minutes.
Okay.
I love your. Yeah. Donations from Mongolia, that is fascinating. See, they drink horse milk. Yeah, they drink horse milk. I thought it's fascinating to me. Yeah, I think, are you supposed to do it? Okay, okay, good. I'm gonna start it.
Welcome back to our programs following the coffee break. We hope you had a refreshing break. And it's now my pleasure to introduce our first keynote speaker, Dr. Linda Abu Jabir from Jordan. Dr. Abu Jabir is a board-certified pediatrician, a distinguished pediatric infectious disease specialist with intensive clinical expertise and a strong commitment to advancing child health. She has made significant contribution to the field of pediatric infection disease. So the title keynote is a whole child immune blueprint, bridging guidelines and interrogative protocol for the post-antibiotic microbiome recovery in MENA pediatrics. So join me in welcoming Dr. Linda Abu Jabir.
Good morning, everybody. As you know, I'm a pediatric infectious disease doctor and a general pediatrician, all of us are, and I'm also a holistic and integrative doctor. So this topic is very important to me, and I hope it'll be important to you because a lot of you use antibiotics, and I think that we need to be very careful in our use of antibiotics nowadays. There's a lot of talk about the microbiome, but for me, I like to make it practical because life is all about being practical to me. So we're trained, the pediatricians and the doctors among us are trained to diagnose an acute problem, treat it, and then we're done when the symptoms are gone. But the problem is, especially in the MENA region, I don't know what it's like in your part of the world, but we have a problem with a high incidence of antibiotic resistance. And part of the problem is people. Who is going to present the thing about social media? Social media is a problem now in terms of in terms of causing antibiotic resistance. I want to, when we can't give antibiotics and when antibiotics are not indicated, nobody really teaches us what to say. The watch and wait thing doesn't work anymore because we're dealing with pharmacists and we're dealing with social media, we're dealing with ChatGPT, we're dealing with all these people that are telling our patients and the parents, you got to do something, you got to do something. So I want to propose something that you can actually teach the patients to do in the meantime, besides giving antibiotics that are not needed. I want to break the myth of the course of antibiotics does not make a difference in the patient's life, because it does. It really can affect the microbiome of the patient. And I want to give evidence-based recommendations. I'm suggesting them. None of this is like clinically tried and stuff like that, but always in medicine, it's first do no harm. So based on the SPAN and the World Gastroenterology Organization, I'm giving some suggestions as to how to help the intestinal tract and the microbiome and the child in general after we decide to give an antibiotic. And what I'm going to leave you with is why we overtreat in the MENA region, and probably in more than the MENA region, what an antibiotic actually does, because I have so many doctors say, well, it was only one course of antibiotics. Or people come to me and say, well, they gave me half a dose because it was a mild infection. It's like, really? Or, they gave an antibiotic for a cold and the child isn't any better. I mean, these are things that we're dealing with all the time. And I think that we need to train our parents and to acknowledge them and give them something that they can do besides run to their friends or run to the corner pharmacy and say, my kid has a cold and I need a broad spectrum antibiotic. So I'm going to talk about a patient called Ahmed, and I don't know if any of you have seen him, but they're very common in general pediatric practice. Ahmed comes to the clinic. He's not really sick today, but he's had a history. He's 2 years old. He has a history of recurrent cough. He has constipation, he has poor sleep, and he has very bad temper tantrums. And when he was a little baby, he was a very calm baby. So this isn't like he was a really stressed baby or anything like that. So think about this. The baby has a recurrent cough. Nobody really thought whether he might have reactive airway disease or just recurrent viral infections. In terms of his constipation, and in terms of the sleep and temper tantrums, all of these symptoms can be actually brought back to the effect the antibiotics had on his microbiome. Okay? The microbiome is the bacteria that lives in the intestinal tract. So what happened was, in this kid, my theory is he had mixed reactive airway disease. The cough was treated as an infection because she went from doctor to doctor to doctor, or she went from doctor to pharmacist. If she didn't get the answer she liked, she'd go to her mother groups and say, my baby has a cough, the doctor won't do anything, what am I supposed to do? So her friends would tell her, oh, I gave my kid this broad spectrum antibiotic and they got better. Okay, and this is a problem that we're all dealing with. And I want you to know that before we start pulling out drugs and treating with bigger, more broad spectrum antibiotics, we need to know that the recurrent cough, the constipation, and the sleep and the temper tantrums can really be an effect of the antibiotic affecting this kid's microbiome. Okay. So in WHO numbers from 2025 and the glass, 1 in 6 bacterial infections are now resistant to first-line antibiotics. Can you think about how serious that is? That's 1 in 6. You know, you can't now. When I was a young doctor, amoxicillin would kill anything. Now the women, when moms come to me, they don't even know, they're not familiar with amoxicillin alone. They're all talking about Amoclan, which is amoxicillin clavulanic acid. I actually had a mother the other day. I told her, you need to go get amoxicillin. She had to go to 3 pharmacies before she could find plain amoxicillin, which is still standard of care for like an ear infection. Okay. In the MENA region and in the Eastern Mediterranean region in general, the number of antibiotic resistant bacteria is even higher. We have 1 in 3 infections are resistant to first-line antibiotics. So we're talking like E. coli. A little kid comes in with a urinary tract infection. 48 to 76% of them are resistant to third-generation cephalosporins, for goodness sake. Okay? The Klebsiella pneumonia, which is a lot less common in babies, but it's more than 50% are resistant to third-generation cephalosporins, and we have a more than 30% rate of methicillin-resistant Staph aureus. Can you imagine that? 30%. Because remember, we're talking about like big numbers. 30% doesn't sound like a lot, but when you're dealing with 10 million people, that's a large number. Okay? And then in Jordan itself, we have a 59% resistance rate in Staph aureus. 59% of the staph is resistant to methicillin, which means you got to give kids even more broad spectrum antibiotics, 3rd generation, 4th generation cephalosporins. You got to give them meropenem. You've got to give them clindamycin, which is really, really bad for your microbiome. And in a single center, the E. coli resistance to ampicillin, which used to be the standard of care for urinary tract infection, is almost 90% resistant. Okay, and 47%, 50% is resistant to amoxicillin clavulanic acid, which is a broad spectrum antibiotic. Okay, I'm sorry I'm getting excited, but these numbers are very frightening for you guys, because I'm on my way out. You're on your way in. You're going to be dealing with these infections. And 50%, the E. coli, which causes urinary tract infections in kids, is 50% resistant to Cipro. Can you believe that? And then our problem, and one of the problems in Jordan, this is an older study, but it's very, I actually went last week and talked to different pharmacists, and 74% of pharmacists will dispense antibiotics without a prescription in Jordan. Okay. The mother goes, my kid has a sore throat. Oh, here, take some Augmentin. They don't say go to the doctor, or they say go to the doctor, and the doctor, they said we already went to the doctor didn't do anything. So we need something. So what we're dealing with I think in the world in general, not just in the MENA region, I don't know what it's like in your regions, but first off, the pharmacy. You go to the pharmacy, the people say, well, I can't afford to go to the doctor, give me a drug. They give drugs, and they don't even give the small like amoxicillin first line. They immediately go to the second and third line antibiotics, which is very damaging. The parent comes in, they want us to do something. I don't know. You're an intensivist. You're a OBGYN, right? You know, the mom wants you to do something, right? My kid's sick, do something for me. A lot of times it doesn't have to be an antibiotic, but we need training in what are we going to give them instead of an antibiotic, right? So I'm suggesting some things here which are evidence-based. Okay, the network. Auntie Nyla gave this. My friend took that. And I'm on some mother's group in Jordan, and they go to the doctor and they ask I went to the doctor said to take this. What do you think? And everybody has an opinion. So they might not like what the doctor said, so they'll go back to the corner pharmacy and say, well, I need something more broad spectrum. Okay, and then the algorithm, ChatGPT, Claude, all the AIs are they're very good about saying an antibiotic, but I'm also noticing that they're very good about saying you should go to your doctor. But that's not what happens when you have access to antibiotics. The treatment of this is this, so they haul themselves to the pharmacy, get this broad spectrum antibiotic, and then they ruin their child's microbiome or their own microbiome. Because as an older doctor, I'm looking at all these kids that are overweight, that have asthma. This didn't used to be the case in children. They used to have acute illnesses and then they would get better. Now they're not. It's like having elderly people. They have diabetes, they're overweight, they have obstructive sleep apnea, they have school problems, they have behavioral problems. This is not the way children used to look. And I think this is actually one of the problems in that, plus all the pesticides and the insecticides and the fact that we're relying on processed foods. But this is one thing that as doctors and educators that we can do something about, is educate people. You know, an antibiotic is not just doesn't just affect you now. In this little boy, like when a kid comes in with a recurrent cough, a 2-year-old, it could be that he just has bad luck. He goes to daycare, he keeps getting upper respiratory infections. But by giving an antibiotic, we're making him more susceptible to infection. By giving him an antibiotic, we're making him more susceptible to reactive airway disease, to allergies. Okay, and I'll show you the mechanism of that in a minute. But always, as clinicians, whoever of you deal with children, I want you to always think when a child has a recurrent cough, please let's put it through the lens of what are the causes of recurrent cough. And one of the things is either preschool viral-induced wheeze, reactive airway disease, or asthma. Okay, these are things that can happen in children. And how you differentiate them just from bad luck and recurrent viral infections is the cough with reactive airway disease persists after the symptoms of the virus go away. So you have a kid, he's sick for 10 to 14 days with a cough, all the other symptoms go away and he continues to cough. Or he gets a cough when he's exposed to cold. He gets a cough. I don't know if any of you have seen this, but sometimes a 2-year-old will be running and then he stops because he can't breathe and then he'll start up again. That's reactive airway disease. It's not a viral infection. It doesn't need antibiotics. The triggers in children of reactive airway disease are exercise, like this kid that keeps running and can never get in shape. Allergens and irritants like cigarette smoke. And I don't know what smoking is like in your areas, but in Jordan, I think 90% of the population smokes. So we get these kids that never stop coughing. And then what happens? They get on an antibiotic and then they get on another antibiotic and then they're on another antibiotic and the mother comes to you, I don't want to give my kid any more antibiotics, but I don't know what to do. Okay, so this is what we're talking about today. Now, what antibiotics do? So many doctors say, or moms will come to me, well, it's only one course of antibiotics. But do you realize that within 48 hours of giving an antibiotic, a broad spectrum antibiotic, 25 to 35% of the microbiome is killed, which means there's a vacuum for things that are bad. C. difficile, vancomycin-resistant enterococcus. You know, these bad pathogens that the microbiome protects us against. There's a vacuum. It's going, here I am. I'm empty. Come on and come into me. We have the bifidobacteria, Akkermansia fecalibacterium, and Roseburia are very important in keeping our intestinal tract safe, which keeps our respiratory tract safe, which keeps our brain safe. Okay? And then we get collapse in the short chain fatty acid production, which means that we're not regulating our brain and our lungs as well as we should be. Okay? So whenever somebody says, but it was just a little antibiotic, you might want to tell them that this is not really as benign as you would think. So the bacteria that are lost and what it costs the child. This is a very complicated looking slide, but basically, when we lose bifidobacteria, that is the bacterium that helps coat the intestinal tract with mucus, which keeps it safe, keeps things from leaking into the blood. And it's the area, the gut-associated lymphatic tissue has to do with training our immune system. And we want our immune system, especially like in newborns and neonates, to be trained so that we have more of the Th1, which is the protective factors, rather than the Th2, which are the ones that cause inflammation and allergy. And I think that's one of the reasons why we're seeing so much allergy is we're not training the immune system properly anymore. The fecalibacterium and Roseburia, they actually make the fuel that feeds the colon cells. So when you don't feed the colon cells, what's going to happen? The colon is going to slow down and you're going to get a kid with constipation for no apparent reason, who refuses to poop, cries when they poop. And it doesn't sound like a problem, except if you've got a kid that won't poop. And then it's a big problem for a lot of people, and that's all they think about all day. In terms of Akkermansia, it makes the mucus shield, and the mucus shield is important because it protects the gut lining of the gut inflammation, and it stops the cells of the gut from separating from each other. We've all heard of chronic inflammation, you know, all these chronic diseases where we talk about inflammatory cells and inflammation. The gut is the root of this chronic inflammation because when the cells separate from each other, when we mess with our bacteria, the lipopolysaccharides, which are proteins from the intestine, can get into the blood, and then everything hurts. You know, I don't know if any of you have experienced this. You're probably not in the right age group, but these kids that come in, they don't look like there's anything wrong with them, but they're always hurting. They never have enough energy. They're sleeping well, because that's actually one of the things I always ask about. They're sleeping fine, or they seem to be sleeping fine, but they're just not normal. And that's one of the reasons is a leaky gut. And the L-rhamnosus also keeps the cells of the intestinal tract close together so that there's no leakage. Okay, so whenever you're thinking about giving an antibiotic because the parent thinks the baby looks sick, or because, you know, the parent herself doesn't look well, I want you to remember this slide. You know, this is all the things that the antibiotics will do to you. Now, if we leave the child alone or the adult alone to recover afterwards, here's what happens without any special support, okay? First, we have the acute dysbiosis, which is the first 2 weeks, okay? Which means there's a vacuum. And you know, nature does not like a vacuum. So if we kill all the good stuff, bad stuff is going to come in, specifically like C. difficile or vancomycin-resistant enterococcus, okay? Then within 2 to 6 months, there'll be recovery of the intestinal tract. The poop and everything will look good, but the basic pioneer, the basic healthy bacteria still have not come back. Okay, and they need help in order for us. They need help to come back properly. And then some of them take up to 2 years to come back. Our pioneer, which are the ones we talked about in that other slide that actually keep our intestine healthy. And then when you use things like clindamycin, which remember I talked about because of the MRSA, there's a study, it was done in adults, okay? So I don't know if we can extrapolate it to kids, but I don't know why we can't. Showed that it takes After 8 years, the pioneer strains didn't come back after clindamycin. Can you believe that? 8 years, and the bacteria in the intestine is still messed up. And I don't think that's healthy for us. And that might explain all these incidences of unexplainable stuff, why people are acting the way they're acting. Okay? So, in Ahmed's case, he had 7 courses of antibiotics. The poor kid never got out of the acute dysbiosis. He was never able to recover his intestine, his microbiome properly, and actually, this is a very important sentence. The nest infection was being prepared for by the antibiotic. Okay? So here's why the gut and the lung are connected together. It looks like it's esoteric information, but it's actually very important clinically. Okay? So cell trafficking it's not like human trafficking. It's actually a good thing. And what happens is the majority of the immune cells are trained in the intestinal tract. So if they're trained wrong, we're not getting enough interferon, we're getting the wrong types of cells going to the lungs. Okay? So they don't protect, and they tend to send the child towards inflammation and reactivity rather than being cured. In other words, we give the antibiotic. The next time the baby needs their immune system in the lung, instead of going and protecting, what happens is these cells that go cause inflammation in the lung. So the kid starts to wheeze and to cough, and nobody can explain why that's happening. In terms of metabolites, the intestinal tract, the bacteria and the intestinal tract make short chain fatty acids. Who cares, right? But short chain fatty acids have a lot of functions in our body. Number one, they feed the other good what do they call them? The germs. They feed the good bacteria that live in the intestinal tract. So what is made the end product or the waste product of one bacteria is actually food for another bacteria. So if that isn't present, the food isn't present, the other bacteria dies out. So it's kind of like a domino effect. The alveolar macrophages actually need the short chain fatty acids to make an immune defense, to make interferon, and to make the mucus that actually helps the lungs. So you don't have that, you're not protecting your lungs properly. And interferon itself is one of our most important protectors against bacteria and viruses and parasites. So if we don't have that in the lungs, we're going to get problems. And this is something I didn't know. The bone marrow, if you don't have enough short chain fatty acids, your bone marrow does not produce the right TH balance. There's the TH1 and the TH2, the T regulatory cells. What those are is one is responsible for defense and the other is responsible for inflammation. And I think overuse of antibiotics is actually responsible for a lot of our chronic diseases right now, that and a whole bunch of other things. And then in terms of barrier antibodies, when we don't have a good microbiome, we don't make enough secretory IgA. It's as simple as that. And secretory IgA is what covers all our mucous membranes. So we don't have enough secretory IgA. We're not really protected against viruses. We're not protected against bacteria, okay? And we have the gut inflammation. You're all familiar with leaky gut syndrome, yeah? Where the stuff gets into the blood, you just don't feel good, or you start getting allergies where you didn't have allergies before, or you get like arthritis, autoimmune diseases. These all are, if not caused directly, they're made worse by the leaky gut. Okay? So in terms of why the change in microbiome, again, this isn't proven, but these are all independent mechanisms that show how the microbiome affects the brain. The vagus nerve is actually directly affected by the bacteria and the short chain fatty acids. So if the vagus nerve isn't sending nice calming responses to the nervous system, the kid gets anxious. The HPA axis, the hypothalamic pituitary axis, it actually makes it more it upgrades it. It makes it more secrete more cortisol. So you have a baby that used to be calm, or an adult that used to be calm, and now they're all anxious. They can't calm down because their cortisol level is high. just because they aren't making enough good things in their intestinal tract. The neurotransmitters, 90 to 95% of the body's serotonin, not the brain serotonin, the body's serotonin is actually made in the intestinal tract. Serotonin is responsible for, how we feel in our, if we feel in our gut or not. It's responsible for inflammation. So when we have dysbiosis, we have more inflammation in the body. We get brain inflammation. I don't know if any of you have had this, but sometimes you just feel like you're going crazy for no apparent reason, or you're anxious, or you can't focus, you can't sleep. All these can be caused by a disrupted microbiome. So, in terms of long-term effects on children, studies have shown, and this is important for you, Dr. Omid, is there is a definite interaction or relationship between giving broad-spectrum antibiotics to young babies and with asthma and allergy. And it also is a direct effect causing obesity. And it's really interesting to walk around the streets and seeing all these little overweight kids that we didn't used to see before. And that could be due to the microbiome being disrupted. So in Ahmed, why does he have constipation even though he's not sick? It's because he's not making enough short-chain fatty acids and he doesn't have enough mucin in his intestine. For the gut lung, he's getting a recurrent cough because his immune system isn't working very well in his lungs and because the T regulatory cells are shifted towards inflammation and away from protection. And for the gut-brain axis, he can't sleep. And he has bad temper tantrums because his HPA is hyperactive. He's running on cortisol. He's not making enough GABA, which is a calming hormone. He doesn't have enough serotonin, which means that he just doesn't feel right in his body. And he's got some inflammation in his brain from all these nasty things in his blood that really shouldn't be there. So he's not a difficult child. He has a disrupted internal environment, okay? So my suggestion here is that we need to do some things to make this better for him, okay? So one thing I want to talk about as an infectious diseases doctor is before we give an antibiotic, we need to document that there's definitely a bacterial infection and that there's nothing else going on. So the child looks sick is not an indication for an antibiotic, especially not a broad spectrum antibiotic, or the parent is worried, or somebody said, I won't leave here without an antibiotic. Okay. So what happens is we can evaluate, and if we just need watchful waiting, because I'm not the American Academy of Pediatrics and the IDSA, which is the Infectious Disease Society of America, have put out guidelines when to use antibiotics in common upper respiratory infections and when not to use them. So when not to use them, you have a child with a 38.5 temperature, their snot is running down, they're coughing, and you're telling this parent, I'm not going to do anything, we're going to do watchful waiting. I'm going to suggest to you some stuff you can do besides filling out a prescription for antibiotics, okay? Because we need to give the parent a written plan. Parents need to know, you can do this, you can do this, you can do this, you can expect this. If this happens, you need to come back. Or in some cases, if you have a reliable parent, you can give them a prescription for an antibiotic and say, don't use this unless this, and this happens, and call me first. Okay? So it's predicated on having a good relationship with your patients. So are you familiar with these guidelines? Do any of you need to be familiarized with them? No, you know them? Okay, so this is the acute, if any of you wants them, you can just email me and I'll send them to you, okay? So how we're gonna say no to the parent when they don't need an antibiotic. They've got the 5th upper respiratory tract infection in 6 months, which is actually part of being in daycare, for those of you who deal with kids in daycare. So what are you gonna do? First off, you tell the parent, I'm really glad that you came in. It's for me to examine the baby. Okay. And then you tell the parent, because usually we know based on the way something presents and the time of year, we can actually give a diagnosis. This is the name of the virus. Like this is RSV and this is how I expect it to behave. This is something and this is how I expect it to behave. Because parents need to know that you actually know what you're doing. And this is one way we can combat the social media effects. And then you give an active plan. You know, here's exactly what you can do for your baby. And then you say, here's what you're looking for. If these things happen, or if you get worse, or if, you just depending on what is going on. Like, let's say the baby has gastroenteritis, you need to tell them, "Oh, here's what I expect to do. This is what you're going to do. If they show signs of dehydration, tell them exactly what it looks like. And then you send them home with these written down. And the nice thing is they're general, and you can print them out, and then you can give them to whether they're gynecology or obstetrics patients or their children, you can give them written things. So, and then a parent who's extremely anxious, because I'm dealing with a lot of very anxious patients lately, you need to give them the antibiotic, and you can tell them, don't use this, and please call me before. And then this way they have it in their hand. They don't have to go ask their friends. They don't have to go to the corner pharmacy. You're doing proper antibiotic stewardship, because you tell them amoxicillin and not augmentin or clindamycin or something like that. Okay, so traditional remedies. In the Middle East, we use a lot of traditional, and I'll bet you guys do it in Tunisia, in Kazakhstan. People use traditional remedies, the things that your grandmother tells you to take during an infection. So honey and lemon is actually proved by Cochrane to work just as good as diphenhydramine, as Benadryl, when you have an upper respiratory infection. So you can actually recommend that and say there are studies that prove that this works. Okay? And obviously, never give honey before a year of age, because you can cause botulism. Yes, that's an absolute contraindication, is in a child less than a year. So nasal saline and a cool mist humidifier. That's two things you can tell the parents to do. And teach them exactly how to suck the nose out. A lot of parents don't know how to suck the baby's nose out. And you want a cool mist humidifier because it helps shrink the mucous membrane, rather than a warm one grows more bacteria and mold, and it can also make more congestion. So you want the cool mist humidifier. So that's another little conversation you can have with the parent, because what you're doing is you're building a relationship. We're not building enough relationship with our parents. And well, I don't know about you guys, but when you have to see 30 to 50 patients, it's really hard to build a relationship, especially when you know that if they don't like what you say, they're going to go to another doctor or to the corner pharmacy. Ivy leaf actually is, I started researching ivy leaf because I found it in a lot of pharmacies in Jordan. And the active ingredient of ivy leaf is alpha heterin. And what it does is it sends a message from the gut to the lungs to actually make the cilia beat faster. So you have better mucus clearance. It says that you can, there are varying ages on this, but I would rather go for the ivy leaf. I would rather maybe only use it after 4 to 6 years of age in preschoolers, because there's not been good studies in less than that. Okay, but you have a cough, you can say you can use some ivy leaf syrup. And then pelargonium actually has been studied with, it's an antiviral. It's actually a very good antiviral. And the interesting thing is, in 2025, in the journal Pediatrics, there was a study that showed that it actually helps with the symptoms of pharyngeal tonsillitis. So a baby comes in. I've had a whole bunch of moms calling me over the last week. My child has a big red throat. They don't really want to drink. They've got a fever. And what do you think the first thing I tell them to do? Somebody want to interact? I tell them to go get a throat swab, because that's the only reason you should give antibiotics to a child with a red throat and a fever, is if they have strep. Okay? It's the only reason. And if they do have strep, you need to use plain old amoxicillin, not augmentin, not anything more sophisticated. Okay? So I've had a slew of these kids with negative throat swabs. So what am I going to tell them to do? I tell them to use things like this. Okay? An older child can do some gargling. Garlic is actually, allicin has real in vitro antiviral activity. So I use a lot of garlic. I'll say use some garlic and mashed potatoes. Use some garlic and yogurt, because yogurt actually has active bacteria in it, helps restore the microbiome. In terms, I didn't finish my pelargonium point. The pelargonium, in an adult study, it showed no relief in symptoms of bronchitis. But when the doctor gave the patient pelargonium, there was a 31% decrease in antibiotic use. So that to me, that's a very huge effect. Maybe it didn't make the symptoms better, but it made unnecessary antibiotic use 31% less likely, which to me is important. Okay. In terms, ginger, we all know, we've heard ginger, chamomile. Chamomile has been studied. It actually is an anti-inflammatory. So I use it in the kids. We use a very weak tea of that. And that also helps because when you get a cold, you don't want to drink and you can get dehydrated as a baby. So you can give them little sips of chamomile tea. Thyme tea, za'atar is what we call it in the Middle East. It may or may not have some effects, but when you have a child with a cold and the mother's saying, I don't know what to do, a little bit of za'atar tea comes in very handy. Thyme. And the active ingredient is carvacrol. It actually has been studied, and in small studies, it does thins the mucus out, and it's an antispasmodic. It helps with cough. But they're small studies, but they're not, as long as they're not harmful, I always think it's all right to use it. Now, yansun is something that the Arabs use a lot, and that can be very dangerous because anise, the true yansun, is not harmful. But usually what people get is anise tea, which has either Chinese or Japanese anise. And the Japanese anise is actually toxic to the nervous system. And it can cause irritation, it can cause reflux, it can cause vomiting, it can actually cause seizures. And I actually did a social media post on that. And a few moms actually called me and they said, you know, I stopped giving the baby yansun or the anise and my baby calmed right down. Because people don't realize that. They think because we've been using these things, and I know in India and Mauritius and Kazakhstan, we use a lot of traditional things. So it's really important that we talk to people about that because that's one way to make a relationship that ChatGPT and Claude can't. Right? And isn't the relationship more important than anything else? So this is what I would recommend handing to the moms. Tell the parent you need to keep them hydrated. Give them ideas about hydration. Tell them how much the child needs to take. The baby won't drink is what they're going to say. You can say, well, take a little syringe and give a few drippity drops here and there. And over the course of the day, they need to take this much. Okay. Sleep and rest is highly underrated. Most of the repair work and antiviral work in our body is done when we're in deep sleep, right? Have you ever woken up? Well, we've all woken up as doctors from the middle of a deep sleep and everything hurts. That's because we were in the stage of healing and then we were woken up at the wrong time. Well, maybe you guys don't feel that, but I do when I'm woken up at the wrong time. And then you want to give varied nutrition. And why this is really important, and most people miss it. If you don't, there's not one food. Everybody wants to know what food boosts my baby's immunity. There's not one food. It's a mixture of a variety of different things that's going to boost your baby's immune system. And breastfeeding is really important. And it's really important that we support our mothers in breastfeeding, you know, because it's a hard job. It's very time consuming. It's very labor intensive, but it's really, 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 really worth it. Okay. So here's what I would recommend that you can give to the parents. Like, here are solutions for each different age group. Like a 7-year-old, you have them clean their nose out. You can give them some pelargonium. You can give them some ivy leaf. You can tell them, you know, don't go to school, take some sleep. I don't know any 7-year-old who won't say, I don't want to go to school for a day. But that actually will decrease the incidence of, or it'll shorten the length of a cold. Okay? Now, here's something that I am suggesting based on a couple of studies, the ESPAN and the World Gastroenterology Organizations. Whenever we have to give an antibiotic, if it's truly indicated, then two things that we can start that will help protect the microbiome. One is Saccharomyces boulardii, and it has to be that strain. And you shouldn't give it in very low birth weight infants. You don't want to give it in people with to oncology patients, especially if they have a central line. But if you have an otherwise normal child, Saccharomyces is a very good additive and we start it with the antibiotic because it's a fungus. It's what do they call that? It's oh my goodness, a yeast. And it's resistant to antibiotics, so you can give it with the antibiotic. It acts as a decoy receptor for pathogens. Pathogens will actually go, like viruses or bacteria, will actually go and connect to the Saccharomyces and then get pooped out rather than actually infect the intestinal tract. And it supports the tight junctions and protects babies against leaky gut. Okay, and you can start it. Here's the doses and everything. You can start it on day 1 and you continue it the whole time the child is on antibiotics and then for about a week or 2 after that. Okay, and actually in studies, it does decrease, it prevents antibiotic associated diarrhea. And we've all dealt with that, right? And then lacticacibacillus rhamnosus or LGG. It supports the tight junction. So that's actually another thing that we should give when we start giving antibiotics. And it prevents antibiotic-associated diarrhea. You can either give it 2 hours after the dose of antibiotic, or you can actually give it with the antibiotic. Okay? So you start at day 1 and you continue it for 1 to 2 weeks after you use the antibiotic, if you have to give it. Because I know in the mouth and orthodontics, you might be using clindamycin and these broad spectrum antibiotics. So here's something that might help with the babies recovering afterwards. Okay, so I asked this question. I don't know if any of you ever had this question, but can you reseed a microbiome? And the answer is no, you can't. And when you give a broad spectrum probiotic afterwards, there was one study that showed it actually, when you give the probiotics willy-nilly, it delays the native microbiome recovery. It makes it go slower. So you don't want to do something like that. But what is evidence-based after the course is nutrition. Nutrition and food is very, very important. So you can use indication. There's certain probiotics for certain things, and I'll give you the list of that. We want to feed the child's native bacteria. We want to help the child's own body recover. And how we're going to do that is we're going to use high fiber foods. And I'll give you suggestions here on high fiber foods. And again, try to stay away from sweets and fatty foods and fried foods, processed foods, and things like that. And when you explain this to parents, they actually listen, because usually they roll their eyes, right? Stay away from sugar, stay away from fried foods. And they're going, but that's my kid's favorite thing. But if you tell them exactly why that is, they actually, you have a higher incidence of getting compliance with that. And then time. Remember, if you give a course of antibiotics, really, really, really try to wait a long time before you give another course of antibiotics, because there's a lot of pressure now. Oh, my baby isn't better. And you want to give another one, and then you give another one. So that's why it's so important to give alternatives to the parents. Okay, so here's the probiotics that have proven by studies to work for certain things. The S-Boulardii stops you from getting antibiotic-associated diarrhea. L-rhamnosus, the same thing. These are very strong indications. L-reuteri and B-lactis, because you deal with preemies and stuff like that. Those are very helpful in colic in babies. These 2 strains of bacteria. And they've been studied and they show that they help, but again, it's not very strong indication. But in terms of feeding the baby, that actually is proven by the East End study and by the World Gastroenterology Organization. So in 0 to 6 months, we want to use breast milk as much as possible. If we have to give an antibiotic, breast milk, because the HMOs, the human milk oligosaccharides actually help feed the microbiome and make it better. From 6 to 12 months, we want to use iron-rich food. Again, iron is part of the immune system. We want to use the bitter greens, like broccoli, the ones that smell bad. The sulfuric acid, the sulfur compounds in there actually help boost babies' immune systems in general. And like you need soft fruits for the fibers. Olive oil is very good. It's just it's a mono saturated fatty acid. And then you want plain yogurt for the fibers. I mean for the healthy bacteria in there. And then you want to use well-cooked vegetables and fruits because the non-soluble fiber is what feeds the bacteria in the intestine that make the acetate that feed the other bacteria, which is why fiber is so important. Okay? And then for the 1 to 3 year old, the same thing, but we definitely want to limit sugar because what does sugar do? It feeds everything, including the bad bacteria that we don't want. Okay, and then the ultra processed foods really have no value in them anyway, so it's best to avoid all those. Okay. Now, my thing is, how do we prevent people from getting sick in the first place, if at all possible? So here's a few suggestions. Number one, if we can get mothers breastfeeding, isn't breastfeeding proven in preemies to be very helpful and it helps neck and stuff like that. I mean, breastfeeding is really, really important. And as an obstetrician, it's important to support mamas because it's not an easy thing to do. Breastfeeding, we talked about. Vaccination, we're dealing now with after the COVID vaccine, nobody wants to vaccinate their kids anymore. Vaccines do this, vaccines do that. So it's really important to sit and have a conversation with our parents. And as an older doctor, I can say, I've seen meningitis, I've seen whooping cough, I've seen epiglottitis, and I'm not that old. But people tend to forget because we don't see these illnesses anymore, that the vaccines actually prevent these horrible diseases that kill kids. And measles, for instance, because nobody wants to give the MMR now because they think it causes autism, right? They forget that measles can cause a pneumonia that can kill you. It can cause encephalitis and all sorts of different things. And it actually can kill you. And people forget that. So I think it's really important to talk about that. Eliminate secondhand smoke. I'm sure you talk about that with your cancer prevention. Did you know, I used to tell parents, okay, you can put your clothes on and then put a jacket on, and to smoke and then take the jacket off and come inside. And that's mildly protective. I mean, instead of the stuff that sticks on the clothes. But even new studies have shown that even when they're smoking anywhere in the environment, it increases the incidence of SIDS, which has nothing to do with this talk, but it's really important. And it increases the incidence of ear infections, upper respiratory infections, and allergies. So it's really important that we give, people a reason to stop smoking or maybe not start smoking in the first place. And then we need to teach kids about daycare, wash your hands, wash your hands, wash your hands. And then when we choose a daycare, it's really important that we look, I give my parents a check sheet for what to look for in the daycare. How many wash basins are they? What do they do before? How many? I mean, are the daycare providers immunized? Is there a system in place for hand washing and things like that? When the baby is sick, what do you do? Okay. So this is, I can't tell you that there's been a lot of studies on this, but I've used it. I've actually started using probiotics back in the 90s before it was a big deal, but the science made sense to me. And I've been using them and I do notice that they really do make a difference in children. And now they're coming up, they're catching up with me and they're doing the studies that prove that. Okay. In terms of the gut brain and the gut link axis, I can't say that there's proven studies, but it does make a lot of sense. I don't know how many of you said after my kid got sick, they can't sleep. After my kid got sick, they stop having temper tantrums. And it does seem to be associated with antibiotic use. So, and then again, please, 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 before you give an antibiotic, make sure that it really meets the scientific indications for that because we're under a lot of pressure as clinicians to do something. So instead of doing something, let's give, instead of the antibiotic being the do something, let's make it do this, do this, do this. And I gave you some suggestions, some actual concrete suggestions that are based on science. Okay. So as doctors, I think our job is to have two types of stewardship. The front end is to only use an antibiotic when indicated. Try to use amoxicillin rather than Augmentin or the third generation stuff. Go Narrow spectrum is possible, and now the studies are showing, like for acute otitis media and a kid more than 2, we can treat for 5 days. Strep, we can treat for 5 days. So make sure that you need it. Use the least broad spectrum, so the narrowest spectrum for the shortest amount of days. Okay, and then make sure you watch the kids afterwards to make sure that, the mothers aren't giving them candy because they didn't want to eat and they were sick. And when you explain to them why, I think you'll have more of a success rate. So here's what I'd like you to do when you go into the clinic on Monday. Again, confirm a bacterial cause. Anybody with a recurrent cough, please think of reactive airway disease before you start using antibiotics. Never send the family home with an empty hand. I had in my clinic 30 years ago and 20 years ago, I used to have handouts that I give the patients, and I discovered that they would give them to each other. They would use them like money. Oh, I got your handout from so-and-so, and I came after I did all the things you said, and that's actually really important. And then tell the parents what you will do. Like, the watch and wait, we can't do anything. Don't say we can't do anything. Say, here's what you can do. Here's what we are going to do. I'm going to give you a list. Here's what you can do. And here are the red flags. Okay. When you need to use an antibiotic, remember, the Saccharomyces boulardii and the LGG are actually recommended by science to stop antibiotic-associated diarrhea. And then after the course, make sure you tell the parents how important it is to go high fiber and to feed. There's something called partially hydrolyzed guar gum. If the baby has constipation or diarrhea after an antibiotic and you're sure it's from the antibiotic, you can actually give a little bit of the partially hydrolyzed guar gum. That'll solve the problem. It'll feed the pioneer bacteria and help them come back faster. Okay? And then, like I said, let's try to prevent infections as much as we can. And when we are dealing with the parents, let's name the problem exactly if we can. And then when we say give probiotic, we don't just say give probiotic, you tell them exactly what to give. And that will increase our credibility, our relationship, and hopefully lower antibiotic use and make our kids healthier in the long run. And shukran is thank you in Arabic.
Thank you very much, Dr. Linda. Do we have any question for Doctor? Allow me to present you a certificate on behalf of the organization.
Thank you.
Yeah, okay.
We are now delighted to introduce to you our next speaker, Dr. Mohit Dhiren Bal Patel, consultant obstetrician gynecologist from India. He will deliver a speech on balloon-assisted laparoscopy, surgical tyranny, or preventable surgical incompetence, a control service strategy. Please welcome Dr. Mohit.
Yeah, thank you so much for the kind introduction. So my topic is balloon-assisted laparoscopic cervical osteotomy, and it is a laparoscopic procedure that we have done in 22 weeks of the pregnant woman. So there is no conflict of financial interest or patient consent has been taken care of, because I'm going to show the inside videos of the abdomen. From antibiotics to anatomy, now we are going to proceed. So what is the clinical problem when cervical insufficiency has been coming in your mind? Like, it's a painless progressive cervical dilatation in the second trimester in absence of contraction of the uterus and leading to recurrent mid-trimester loss or extreme preterm loss. So it's a mechanical problem that the structural or the functional weakness of the cervix it cannot retain the pregnancy as intrauterine pressure rises. The silent dilatation can occur, and diagnosis can be done by the prior mid-trimester by the transvaginal sonography or so. Why this periviable window is very difficult? Because from 22 weeks to 26 weeks, the threshold of fetal viability, where every additional day gain the translate the direct into the survival and the reduced neonatal morbidity. So in this window, baby can't be delivered, or it can't be and survived by the neonatologist also. So it is a very, very difficult task to handle. Standard options where they all fall short, like we can do the McDonald's stitch, like a Shirodkar stitch that we can take, and it is an elective procedure that you have to make sure that cervix is not dilated and it is hard cervix. And in hard cervix, you can take the Shirodkar or McDonald's stitch. But we can do the vaginal rescue cerclage, but there is a higher chances of premature rupture of membrane and higher chances of infection also. And we can do the trans-abdominal cerclage while we can have a failed cerclage or something like that. But classically, place pre-pregnancy, we can do the trans-abdominal cerclage pre-pregnancy. But the gap, what is the gap in this three cerclage? That an advanced bulging of the membrane, periviable cervix has no well-established surgical technique or no answer. Why vaginal rescue cerclage often fails? The membrane already prolapsed from the cervix. So while taking the suture, you might be injured the amniotic sac by vaginal suturing, or reduction of the membrane. It will be hazardous to us. And tissue holding, because of the thin cervix, you can't hold the tissue properly, and there is a higher chances of the infection. So in our technique, in a laparoscopic salvageable approach, go above the failed segment and encircle the competent cervicoischemic tissue, not the already dilated distal cervix. That is our primary motto of doing this surgery. So for this, suture site at the true internal os at the cervicoischemic junction, and encircle structurally in such a way that you are not going to injure the uterine vessels or uterine vasculature, and avoid the transvaginal manipulation by doing this laparoscopic cerclage at 22 weeks. And minimal SS approach, less morbidity, less bleeding are there, and tab can be remain inside for the future pregnancy also. Okay, so how do we reduce the bulging of membrane and tighten the cervix at the periviable gestation? It is 22, 23 weeks of the gestation that we have operated the case. I will show you the video without rupturing the membrane and without over or under tightening. This is very important. So it is a balloon assisted laparoscopic cervical tightening, in which the balloon has been made with the Foley's catheter, and we deliberately cut the tip of the balloon catheter, and then we put the balloon inside the cervix. I will show the whole video. We deliberately put the catheter inside the, after cutting the tip, catheter inside the cervix, and then we inflate the balloon so that the tip will be go inside, so it will not harm the membranes. Okay, so we can reduce it, encircle it, calibrate and tighten it, and secure it. So these four things we can do by balloon assisted tightening. So what is the role of the balloon? So balloon can reduce the amniotic sac. That is first. In laparoscopy, we can do the strip Trendelenburg position in modified lithotomy position, so that balloon will be go inside naturally in head-low position. And second, we put the balloon also. So we have two possibilities of reducing the sac. Third, if very advanced gestation sac and 3 to 4 centimeter dilatation of cervix, we sometimes put the amnio reduction needle from abdomen and reduce the amniotic sac, and then we produce with the surgery. Then we go ahead with the surgery. And we calibrate the tension. You have to calibrate the tension of the balloon also. That is around 30 to 60 millimeter of Hg, means 30 to 50 cc, and not more than that you can put according to the size of the balloon or whatever the tension the balloon can be reproduced, and give the counter pressure. So what happens? See, cervix is very much thin when you are doing this surgery. So what happens is when you put the balloon inside, so the amniotic sac goes inside and balloon will give you the proper handling of the cervical tissue, and it will stabilize the cervix so that you can easily glide the needle from the uh, cervical region. So how will you select the patient? So periviable gestation, it should be 22 to 28 weeks or 26 weeks, and dilatation with the bulging membrane or exposed membrane. Confirm a viable fetus should be there, and intact membrane should be there. No labor pain is there, and counseling of the patient is very much important because it's a salvageable approach. If baby is going to be delivered at 24 weeks, it is not going to be survived. And exclude if the patient has a rupture of membrane, any kind of infection is there, chorioamnionitis or sepsis is there, and if there is an active labor, placental abruption is there, and lethal fetal anomaly is there, or any contraindications like anesthesia related or laparoscopy related. So what is the preoperative preparation you can do is confirm the viability of the fetus first, exclude the infection, optimize the uterus with the tocolytics and everything. And you also give the prophylactic antibiotics, and consent and the planning is very much important. So there are teams in the operation theater that can give you the proper support. The anesthetic should be there, that it should be an obstetric anesthetic. Positioning of the patient is also important. Trendelenburg position, uterine handling, gentle uterine handling with the fan retractor, or avoid the uterine manipulator over there. And port position is very much important. If the patient is 24 weeks or 22 weeks size of the abdominal cavity, so you have to palpate the exact size of the uterus over the abdominal cavity, and above 2 centimeter, you have to put the optical trocar, that is 10 trocar, and there should be a surgeon, assistant, obstetric anesthetic, and neonatologist should be informed while doing this kind of high risk surgeries. So first we have to assess and see how the pelvis is there. So we first put the optical trocar, and according to the optical trocar, we put the second and the third trocar. And again, you have to understand one thing. If the patient have a history or something like that, she might be an operated for the endometriosis or something like that. So you can't do this kind of procedures in that kind of cases. If you find an incidental finding of an endometriosis, you can't proceed this procedure. So assess a whole pelvic area and survey the pelvis with the gentle and the atomatic graspers and everything. Identify the uterus, broad ligament, and uterine vessels, and cervicoischemic junction. Identification of cervicoischemic junction is very much important. Second thing is vesico-uterine dissection. This is very important point. Because due to the over-dilatation of cervix or the cervicoischemic junction dilatation, the vesico-uterine pouch, you can't identify it properly. For that, you have to do the dissection from the left round ligament to right round ligament in a such a way that you can't damage the bladder. Okay, so okay. Now, balloon placement and the membrane reduction. See, this video is not running. I will show you whole video afterwards. So in this case, I just already described that we deliberately cut the tip of the membrane, and then we put the NS normal saline inside, so that tip will be go inside and it will be atraumatic. So water to water, we are fighting that inside. and it will be reduced. Cervicoischemic exposure I will show you, and this is the control tightening. You can see this is the area where we put the needle. So uterine artery has a more collagen and this thing. When you glide the this thing needle in this thing, what happens over here is we did three things together. We put the needle downstairs. We put the balloon. While tightening, we deflate the balloon and tighten the cervix so that amniotic sac will be don't coming outside. This is the way you should treat the patient. Now, what kind of complication can occur? So you have to complete the surgery by reperitonizing everything, confirm the hemostasis, and reinform the fetal viability while sonography. And 22 weeks represent a periviable window, a stage where both urgency and caution must coexist. Any intervention carries inherited risk. Therefore, the objective was not merely stitch placement, but structured risk mitigation through visualization, stabilization, and meticulous tissue handling. Given the advanced gestation and membrane prolapse, a laparoscopic cervicoischemic approach was selected to allow enhanced anatomical success and precise suture placement under magnification. Safe membrane reduction was achieved using transcervical catheter balloon. The distal catheter tip was intentionally trimmed to eliminate focal rigidity to minimize the possibility of membrane trauma during inflation. Gradual balloon expansion allowed atraumatic repositioning of the amniotic sac without direct manipulation of the membrane. Port placement at 22 weeks requires thoughtful planning. A 10 mm primary port was placed 3 to 4 cm above the umbilicus to avoid uterine injury and maintain a safe working distance. Additional ports were introduced under the direct visualization. Bladder dissection was performed carefully using ultrasonic energy to expose the cervicoischemic junction. In pregnancy, tissue planes are vascular and friable. Dissection was therefore carried out fiber by fiber, millimeter by millimeter, representing anatomical planes and maintaining the constant awareness of the uterine vasculature. Windows were created into the broad ligaments to facilitate controlled needle rotation and optimal suture angulation. This minimized traction on the gravid uterus and allows smoother, more predictable needle movement. Under magnified direct visualization, cervical tightening was performed at the cervicoischemic level. Sutures were placed over inflated balloon to ensure cautious membrane protection during tightening. Importantly, the inflated balloon provided internal counter support at the cervicoischemic junction. This internal stabilization improves needle trajectory, enhance glide over the uterine vessels, and allow safer suture placement in controlled manner. Following completion of the suturing, the balloon was gradually deflated and allowing the gentle cervical adaptation and preventing the abrupt membrane descent. The procedure was completed without intraoperative complication. Post-operative ultrasound demonstrated restoration of the cervical length and complete resolution of the funneling. The pregnancy progressed uneventfully to the term and delivery was performed by the cesarean section at 9 months, resulting in the healthy neonate. So here the most important point is the distance between the two stitch, that is the from above to down, two tap distance should be less than 2 cm, so that your funneling of amniotic sac will be not coming outside afterwards. So it is a take-home message that interstitch distance should be less than 2 centimeter. Now, post-operative protocol should be very fixed and rigid. Like immediate, you have to give the tocolytics and progesterone hormones or something like that, and surveillance of the fetal well-being after the with the sonography. Lungs maturity, you give the betnazole or corticosteroids to the mother, and activity of the mother should be restored after 6 to 7 hours only, and delivery plan only by the C-section, and put the stitch inside according to the comfortability of the patient. It is something like that. Now, what are the tips and tricks? Reduce the membrane slowly and gently. That is very much important. And use the balloon for the tension calibrator. Stay strictly middle to the uterine vessel. That is very important. Keep the tap flat and untwisted. That is also very important. And this is the Marcelin tap that we have used. And have a low threshold of abortion. If forceful and rapid membrane reduction, you can't do. Over tightening, you can't do. Because if you do the over tightening, it will tear off. Okay. And under tightening, as we already talked, less than 2 centimeter is important. Lateral dissection of the near uterine vessels is very much important. And if there is a more blood flow or blood supply is there, you can't do that. And proceeding despite of infection is a very avoidable things. In carefully selected periviable cervical insufficiency, balloon-assisted laparoscopic cervical tightening offers a control salvageable option that can extend gestation where standard measures are exhausted. So we have invented this at our center, and this is video I'm going to present at American Association of Gynecology Laparoscopy in this November at Boston, held in Boston. So thank you so much everyone for patiently listening me. I have done I'm doing a fellowship program at my center at Ahmedabad with association with the D.Y. Patil University, Navi Mumbai. So if someone wants to join for the laparoscopic training, we are allowed to do that. Thank you so much, everyone.
Thank you very much, Dr. Wade, for your insightful presentation. And I would like to, if someone have any question for Dr. Wade.
From antibiotic to anatomy.
Okay, I will also present you a certificate on behalf of the organization.
Yeah, thank you.
We our next presentation. Please welcome the next speaker, Dr. Ajay Prakash. Virapen Dian, sorry for the pronunciation. Pediatrics fellow in neonatology from India. He'll be speaking from fans to followers, understanding celebrity worship syndrome in the digital era, implication for child and adolescent health. Kindly join us in welcoming Dr. Ajay Prakash.
Thank you. Good morning. Let me start with a question. Like if a 14-year-old child knows every update about a celebrity and spends hours watching the content and being emotionally attached to that celebrity. So is this a normal fandom or is this a danger sign that every doctor should worry about? So, okay. So I'll discuss. So how we move from like being fans to becoming followers, and what are all the implications of celebrity worship syndrome in children and adolescents. So why are we discussing celebrity worship now? So celebrity influence has been there like since 1,000 years, but why are we discussing now? Because the environment has changed. So unlike previous generations, celebrities can be seen only through magazines or televisions or movies. But these days, we have celebrities like everywhere, like in social media, continuously, like 24/7. So the concern today is not only the celebrity influence, which is algorithmically amplified celebrity worship. So because if a child watches a video, the algorithm decides what to be shown again and again to the child, and the child keeps on watching the same. So this is a real case that came to my clinic. A 13-year-old girl presented with sleep deprivation, declining academic performances, and emotional outbursts, and excessive screen use. On clinical assessment, there was no major factor contributing to medical illness, but further evaluation revealed that she was spending nearly 7 hours daily following a K-pop celebrity across various platforms, social media platforms. So again, is this a normal adolescence, or is this a warning sign that everyone should worry about? So why pediatricians should care? Actually, this goes more into a psychiatry, but why pediatricians should care? So we pediatricians not only managing physical health anymore, now digital behavior has become the part of adolescent health. So as I mentioned, unlike previous generations, celebrity exposure is continuous, interactive, and algorithm driven and available 24/7 for the children. So what is actually a celebrity worship syndrome? So it is not a formal psychiatric diagnosis and not in DSM-5 or ICD-11. It is an excessive emotional investment in a celebrity resulting in functional distress or impairment. So actually, Lynn McKitchen first coined the term celebrity worship in 2000. Celebrity worship syndrome exists in spectrums. Coming to level 1, it is entertainment social. For example, I can love a singer for his song. I can love an actor for his acting. This is very normal. Whereas level 2 is intense personal. Like we'll be emotionally attached to that celebrity. Whereas level 3, here comes the problem. This is pathological, where the individual who exhibit uncontrollable behaviors and fantasies about a celebrity, and that affects their day-to-day activity, their attitude and behavior. So moving on to celebrity admiration versus celebrity worship. So as a pediatrician, I strongly believe in admiration. So I tell my adolescent patient should have some role models or inspiration so that they can have someone to follow. Whereas celebrity worship is a problematic thing. So celebrity admiration adds to identity, whereas celebrity worship consumes the child's identity. So healthy admiration is a role model and an inspiration, whereas problematic will cause the functional impairment. Why adolescents are vulnerable? So adolescent is a part of development where the brain is asking 3 questions. Who am I? Where do I belong? So how other person sees me? So for all these questions, the celebrities have answers, that too are temporary answers, which actually affects their adolescence. So the signs of parasocial relationship. It is an one-sided emotional relationship with which an individual feels connected to a media figure who is unaware of their existence. For example, when a celebrity says good morning, like millions of followers feels personally connected. So how many of you have felt like that before? Like if any celebrity has put a video or picture. So coming to the neuroscience of celebrity worship. So the adolescent brain is highly sensitive. It is unable to differentiate whether the rewards are digital or the real rewards. And this is very important. How algorithms intensify celebrity worship these days. As I said before, if a child watches a video within an hour, it shows a similar kind of pages and similar kind of celebrities and similar kind of community groups and DMs, so that a child cannot escape. The child has to watch the similar kind of videos and it becomes an addiction. So what recent research shows about the celebrity worship? So there is a strong association between these psychological disorders and celebrity worship rather than a causation. A child with a celebrity worship can have anxiety, depression, or low self-esteem, body image concerns, and vice versa. Body image and pediatric health. So comparison is the common thing in childhood. So like everyone will have that comparison in the household. That too, especially in Asian households, started comparing like with other child. The similar thing happening now in social media. like unrealistic beauty standards. Instagram have highly filtered images. So adolescents are feeling bad of their own shape and color and everything. And recently there are like many dieting behaviors, which is like very worst, and many adolescents have died because of following certain celebrities and following certain diet patterns. So this is highly affecting the body image and the pediatric health. Next comes the sleep. So excessive celebrity engagement can often lead to late night scrolling. Because of the late night UV lights, the melatonin started decreasing, the secretion is reduced, there is a sleep deprivation, so circadian disruption. So consequently, the child will have poor academic performance, mood changes, obesity risk, and reduces attention. Physical health consequences. As I mentioned, there's no stronger causation, it's a stronger association factor because of continuous screen use, reduced physical activity, obesity, sleep disturbance. Coming to mental health, the same potential association for anxiety, depression, loneliness, and emotional dependency. So these are all the red flags for pediatricians. Before, like we were worried about the screen time. So how much time the child watches the screen. Whereas today, what child actually watches is important because they keep on watching the same content for more than 3 to 4 hours, and that becomes a problem. So these are all the 5 questions to be asked when the child have like higher screen time. For example, how much time they are watching and whether it is affecting the baby's mood or whether it is affecting the baby's academic performance, and how about the interaction with the peers and whether the baby is having a good sleep or not. So we can have simply like 5 or 6 questions to assess in our clinic whether the child is having only admiration or worship. So these are all the common questions we usually ask, like who is your favorite celebrity? How much time do you spend following them? Does it affect your sleep or does it affect studies? So how do you feel when unable to access updates? So these are all the common questions from which we can easily identify whether the child is having just an inspiration or a problematic relationship, so that we can further take the child to a psychiatrist and go for the psychiatric treatment and counseling. So what actually parents can do at home? So I usually tell parents, avoid sounding like stop using phone, don't touch the phone. So our goal is not to eliminate the digital life. Our goal is to give a healthy digital life to the children, because we cannot live without digital media these days, but we should have some rules and regulations at our home. For example, like family media plan, we should have device-free meals and device-free bedtime. And we should encourage real-world activities like playing outdoor for like 1 or 2 hours per day and promote critical media literacy. So what schools can do? Schools actually plays a major role in shaping the children's future. They should have like digital literacy programs, mental health education, as well as a healthy role model discussion and screen use awareness. So this is the pediatric management framework. Like we have to identify whether the child is having an admiration or worship. Then we should assess any functional impairment is there or not. Then we should screen for the psychological problems like anxiety and depression. Then we should have a family counseling. If necessary, we should refer the patient to a psychiatrist. So actually I have a copyrighted work on a celebrity worship syndrome, like beware of icons. And moving on to next, that what will celebrity worship look like in 2035? So these days we are like managing children with the real celebrities, whereas looking at future, it is really scary because there are people can work with like AI companions. They have digital twins, metaverse influence, and personalized AI idols. Will future pediatrician manage attachments to celebrities, influencers, or artificial personalities? It is a big question mark. So to conclude, celebrity admiration is a normal developmental phenomenon. The challenges for pediatrician is recognizing when admiration becomes identity and when identity becomes dependency and when dependency begins to affect their health. Thank you. Thank you so much. So if there are any questions regarding the celebrity worship, can... Thank you. But it should be like a good role model or an inspiration. It should not be a... Yes. Thank you so much.
Thank you very much.
Thank you for the opportunity.
Dr. Jayaprakash, and I will present you the certificate on behalf of the organization.
What do you think of that kid that went out and shot his girlfriend?
Pardon?
Remember that it was in the news? He was talking to AI. This teenager in America. He was talking to AI and he broke up with his girlfriend and he asked AI and AI said, well, eliminate her. It didn't say kill her, but it said eliminate her. And this, I think they're in court right now trying to decide whose fault that was. So, because and it's in court right now. The family wasn't aware. He actually went and killed his girlfriend because she dumped him.
I didn't heard of
You
this.
should,
Yeah.
that's something I think you
Yeah,
should be aware of because it was frightening and nobody knows who to blame. I
Exactly.
mean, the kid obviously was not mentally healthy that he would go to AI. The parents weren't aware of the problem. And AI, I mean, again, AI didn't specifically say kill her,
Kill.
but he said
Eliminate.
eliminate. Or some, it was a word like that, because I remember thinking, oh my God, I mean, that's really scary. So, sorry.
Thank you.
Why is it-
Ready, 1, 2, 3, Maya. Okay, got it.
Do one. There we go. I'm waiting for this thing to come up here.
Now, to complete our final session of the day, we once again welcome Dr. Mohit Dhiranbal Patel from India. He will deliver his second speech on A11-step laparoscopy para-aortic lymph node bisection with Wilhelm hystectomy. Sorry for the pronunciation. Please join again, Dr. Mohit.
Yeah.
Thank you.
So it's a laparoscopic para-aortic lymphadenectomy. I'm going to talk about why we are doing this and what is the importance of this. So these are the disclosure because I'm again going to show you the videos and all. So this topic covers the why para-aortic lymphadenectomy is important, surgical anatomy of this, selection of the patient and the consent of the patient is very much important in this kind of cases. Setup and readiness of the OT is very much important. Step-by-step technique is also a very important point. And danger zones and the pitfalls and the pearls you have to understand. So why para-aortic lymphadenectomy matters? Because the para-aortic basin is the sentinel of the advanced spread of the any kind of ovarian cancer, any kind of endometrial cancer, or any kind of cervical cancer. So accurate nodal assessment changes the both staging and adjuvant strategy in endometrial, cervical, and the ovarian malignancy. The surgical staging remains higher than the imaging study detects imaging study than the imaging study because imaging studies sometimes don't catch any kind of micro droplets of the CA, and that's why this para-aortic lymphadenectomy is very much important. So for the upstaging, it is very important because sometimes occult node we can't actually find out. So we, for the staging purpose, we do the para-aortic lymphadenectomy with laparoscopically. So tailored therapy, because you get to know how much radiation, at what point of radiation, which kind of radiation you required, that we can understand by this. And for after doing this, the prognosis of the patient will be very much good. That's why we are doing this nodes dissection. Okay, so there are the boundaries in anatomy. Superiorly, like cranially, you can go with up to the renal vein, left renal vein, and inferior mesenteric artery. The inferiorly, it's a bifurcation of aorta. Laterally, the ureters, bilaterally ureters, and the psoas muscles are there. And the key vessels are aorta, inferior vena cava, inferior mesenteric artery, ovarian vessels, and lumbar vessels. These are very, very, very much important. So there is one danger try over there that is known as the left renal vein, duodenum, and the lumbar perforators. Because If you can't coagulate and cut the lumbar perforators, it will be shrink inside and the bleeding will continue and it will hamper your field of vision and the operative field. So what are the indication? Though in endometrial cancers, high risk histology and the deep invasion, you have to go ahead with the staging of the para-aortic lymphadenectomy. In cervical cancers, also for the staging, sometimes you are performing in early ovarian cancer in stage 1 or 2 for seeing a micro droplets that can't be catched by the PET-CT also, and enlarged suspicious para-aortic nodes on imaging study. Though cross the sentinel imaging and the histological risk grading and the anesthetic fitness, all are the things that we have to go ahead with the pre-op workshop. And if the patient have any kind of morbidity, obesity that limiting the tendon position or poor cardiopulmonary reserve or extensive adhesions like a frozen pelvis or the rescue abdomen, we can't perform the this kind of surgery. So in these cases, that should be a good informed consent of the patient, the proper thorough investigations, and you have to investigate the proper physical fitness of the patient is very much important. You have to told the patient and the relative in the regional language that might be a chances that you have to open the surgery. If even though you are doing the laparoscopic surgery, there you should have a vascular surgeon with you. Multidisciplinary approach should be there. You have to ready with the 2 to 3 blood in your blood bank, reserve the blood, and you might have a chances to ship the patient to the ICU. This kind of cases and you have to be very much cautious that you might be injured with the ureteric injury, bladder injury, bowel injury, something like that, or a vascular injury, the most probable cause. So here are the 6 ports that we are putting while we are doing the laparoscopic para-aortic lymphadenectomy. One is a supraumbilicus, that is 10 mm port. One is suprapubic, and bilaterally 5 mm ports we are putting. So in this cases, you can see this is the nodal dissection that we have done in 2023. From the ileocecal junction, first we identify the ureter. So identification of the ureter is very much important. And I am using the mechanical analogy. This is known as ultrasonic scalpel. And while you doing this, I just denuding the vessels, ureter and everything. I'm not doing any kind of para-aortic lymphadenectomy. Till now, I can get to know which kind of things I'm dealing with. After that, the same incision we have put on the left side, that from the sigmoid collar, and we merge the right and left incision together. And by doing bilateral this dissection, first we always identify the ureter and the psoas muscle. You can see the beautiful ureterolysis has been done, and the ureter to and fro movement you can always identify over here. So my assistant has lift up the rectum and make a tunnel over the common iliac vein, and then we are going inside and make a tunnel from right to left side, and we detach the rectum properly. This is the very important step you do in the para-aortic lymphadenectomy, so that you have a proper visualization of the each and every structure beneath the peritoneum. Now this is the common iliac on the left side, and we are detaching the common iliac. See, these are the common iliac vessels, and these are the retrorectal space that I'm dealing with. So here the carbon dioxide does the trick. It will go inside and give us the proper champagne effect, so that we can go inside and check each and every organ. See, till the levator ani muscle, I have opened everything, and I am doing the fiber by fiber and layer by layer dissection without damaging any of the structures nearby rectum or nearby the vessels. So this is the dissection that we have performed, and this is the left side of the vein, and that is the iliac vein. And this is the presacral nodes that we are encountered with, and we are removing these presacral nodes very judiciously, layer by layer and fiber by fiber, without damaging the inferior vena cava, because there is a chances of rupture of inferior vena cava, because veins are made up with the elastin and the collagen. So elastin is also a protein, but you can stretch the elastin how much ever you like it. it can't coagulate very fast. But if you have a collagen inside the arteries, arteries have a more collagen. Arteries can coagulate very rapidly and bleeding has been stopped very easily. But vein can't be coagulated that much easily. So you have to give a proper time. So after exposing the inferior mesenteric artery, we shifted our optical trocar from supraumbilicus to suprapubic and changed the whole system from right to left. And then we started doing the para-aortic lymphadenectomy. Now we have shifted the our whole thing. Now you can see this is the aorta and we are dissecting the pre-aortic nodes up to the renal vein. And this is the inter-aortocaval lymph nodes that we are dealing with. Slowly and steadily, till you identify any of the structures, you do not cut anything. This is the primary motto because we are dealing with the great vessels. This is the inferior mesenteric lymph node and this is the ureter. These are the most stickiest and the gluiest lymph nodes that I ever encountered with in my whole life. And these are the lymph nodes that we are dealing with. So always remember one thing, do not tear the lymph nodes because it will cause the lymphoria and it will damage the structures and lymphoria will cause the many kind of infection and everything. So always coagulate and then cut. This is the inter-aortocaval lymph nodes. Here you always encountered with the perforators. So you always see which kind of lymph nodes you are dealing with. And this is the left side of the pre-caval nodes we are dealing with now. Slowly and steadily, gently. So you can see my assistant is holding the lymph node and it is look like something tubular structure. So until you can't understand what kind of structure is there, you can't cut it. So now we can confirm that it is a lymph node only. There is a 4 lymph node group are there up to the renal vein. So we are removing that lymph nodes in toto so that clearance will be very much normal. This is actually a stage 2B cancer of CA endometrium that 50% of the endometrium invades into the myometrium. And that's why we have to perform this case. And it's a very dangerous case. You can't do without any kind of vascular surgeon support or back support like a blood or ICU. And these are the lymph nodes. You can see we have actually removed the whole lymph nodes in toto. And you can see this is the renal vein. Left renal vein. Up to the left renal vein, we have removed everything. And this is inter-aortocaval. These are the perforators that you have to look for. And posteriorly, the posterior longitudinal ligament should be exposed in such a way that no perforator should be damaged. And this is the white fleshy part that is known as a posterior longitudinal ligament. Now whole lymph node are removed. So by seeing this thing, you can actually feel like it's a very complicated surgery. But you have to make sure only 4 things you have to understand: that pre-caval nodes, inter-aortocaval nodes, IMA, IMA lymph nodes, above the IMA and below the IMA, you have to remove the lymph node. There are 4 phases where you have to remove the lymph nodes. So it is an 11-step approach that we have conducted at our center. You can see the beautiful IMA. These 2 are the right and left common iliac arteries. And this is the inferior vena cava, inferior aorta, sorry. And that is the renal vein and the gonadal vein. I can see over here. This is the IMA, inferior mesenteric artery. Superior mesenteric and inferior mesenteric lymph nodes you have to remove. This is the vena cava, inferior vena cava. You can see the beautiful peristaltic movement of the ureter over there. And this is the inferior vena cava. That is the renal vein. And this is the right side of the ureter. You can see the gonadal vessels, the supply of the IPL ligament, infundibulopelvic ligament. It's coming directly from the aorta. So that's why ovarian cancer are more prone to spread all over the body. because it's a direct blood supply of the aorta. So it will be spread it very easily, very fast. And this is the gonadal vein, and this is the renal vein. You can see this is the left renal vein. This is the endpoint of the para-aortic lymphadenectomy. In such a way, step by step, you have to remove all the structures. And this is the left side of the ureter. Proper peristaltic movement, you can see, fairly visualize over there. And this is the final outlook. You can fairly appreciate this is the final outlook of banyan tree. Inside the abdominal cavity, the god has been created. So my point is, so multidisciplinary approach that we already discussed regarding that, that should be there. So vascular surgeon should be informed, experienced anesthesiologist should be there, and large bore IV, 2 IV set, or you can put the central catheter for the patient. Blood grouping, cross matching should be there, and WHO safeguard checklist should be there. Open laparotomy set should be readily available. You should have a bulldog clamp, vascular clamp. You should have a vascular needle holder also. You should have a Prolin 30, 40, 50, 60, whatever you like, you can take it. And vascular needle holder for SEP and for the hemostasis. We have used the T-lift to lift the peritoneum properly so that we can visualize the each and every organs at the basin of the peritoneum. Okay. So uncontrolled bleeding, loss of plane, inadequate exposure, convert early is very important. It is not your failure. If you are going to open the surgery, you are saving the life of the patient. That is not, see, don't do surgery in egoism. Do the surgery for the safety of the patient. That is my golden rule. And there is no gold medal for the bravery. Yeah. So already we know the danger zones, that the left renal vein, lumbar veins, the perforators that we already shown in our videos, and inferior vena cava, the wall is so much thin. So you have to very much cautious while you are dissecting the inferior vena cava, IVC, lymph nodes and everything. Inferior mesenteric artery, many of the time people compromise the inferior mesenteric artery by coagulating, or they didn't know this artery is going to come, and the ureters and the duodenum. These are the areas. So tips and tricks for the safe dissection. Always identify the ureter first, as we already discussed over there. And before energy firing, you have to see which kind of structures beneath your energy. Okay, so I always believe to use thermal and not thermal energy. I always use the mechanical energy that is known as ultrasonics energy. So it's a frictional energy. Okay, so no electrosurgical unit I'm using in each and every cases, because I don't want any kind of electrical current pass through my patient. That is my golden rule of doing a laparoscopic surgery. I use 30-degree scope so you can identify each and every structures. Clip the lumbar perforator by clipping or by coagulating. That is also very important. Stay into avascular plane so that the bleeding has been not that much. Use the gauze piece. If the capillaries bleed are there, use the gauze piece, give the pressure, it will go by its own. Keep the traction and counter traction so that carbon dioxide go inside and give you the proper champagne effect, and you can go in one way. And have vascular control strategy ready before approaching the renal vein. So complications are there. There are many complications. These are very high risk surgery and should be done in a tertiary care center with the high skilled surgeons with the 3D setup or robotic setup. You can perform this. Okay. So proactively, you can do the clipping of the lumbar perforator. Thermal energy, I already discussed that I'm not using any kind of electrosurgical unit. And if you are going to use it, you have to see which kind of rectum portion or arteries or vein or ureter are coming. Don't use open lymphatics, as I already discussed. Don't tear the lymph nodes. Don't tear the lymphatic channels. Just try to coagulate and remove it. And sympathetic chain trauma, nerve injury, you have to understand where the nerve lies. That is also a very important point, because there is an IHN nerve. The presacral nerves are there. So you have to understand. So if you are in a proper plane, nerve will not damage by yourself. So it is an also important. So this particular slide shows that open para-aortic lymphadenectomy versus laparoscopy. So in open, you can see there is a lots of blood loss, hospital stay is higher, and the recovery is longer duration of time. And all three are very less in laparoscopic surgery. This patient has been gone home in 3 days, and no radiation should be given. Everything is fine. Total clearance has been taken care of, and patient is pretty much good now. So take home message is para-aortic nodes status drives staging, prognosis, and adjuvant therapy. In first slide, we have talked regarding that. And specific informed consent you have to take because it's a very high risk surgery. Be prepared with the vascular surgeon, open set, bulldog clamp, and everything. Work in avascular plane, that is very much important, so that you can control the lumbar perforators and the renal, any kind of nerve injury should be prevented, and respect to the danger trial like renal vein, duodenum, lumbar vein, and IVC, inferior vena cava. So thank you so much everyone for patiently listening me. This is all from Dr. Mohil Patel from India. Thank you.
Thank you very much, Dr. Mohit. We sincerely thank you for your excellent presentation. You have done 2 presentations, and we'll also present you a certificate on behalf of those organizations.
You.